Okay, sorry, can you hear me now?
Yes, great.
Oh, sorry about that. I gather, well, first of all, thank you for the invitation, Matthias, and I'm excited to be here. And I guess that you can see my screen now, right?
Yes, we can see it.
Okay, so what the SPIN study is about is a retrospective multi-center study to evaluate the current value of performing stress CMR perfusion studies in the United States in assessing patients with chest pain syndrome who presents to have a referral for cardiac MRI for evaluation of ischemia. So the premise of this study is the fact that while stress CMR has shown a remarkable diagnostic accuracy for coronary stenosis, detecting coronary disease in many single and multi-center studies, and also MRI has shown in single-center studies that it has high prognostic values in the experienced centers. It is uncertain whether stress CMR is able to make strong impact in patient care, and also there's a discrepant utility of this technology in the United States, in the sense that less than 1%, indeed about one in 1,000 out of the 2 million cases of stress imaging for evaluation of stable chest pain syndromes in the United States is utilizing stress CMR. So given that we wanted to do this study to look at the current use of CMR in terms of its ability to associate cardiac outcomes, and also the implications and ramifications of a stress MRI in terms of downstream testing and impact on healthcare cost. So back in 2012, we set out to work out the support with the SDMR registry, just get some funding support from SDMR to perform this study that involves 13 centers across 11 states in the US to retrospectively gather data from consecutive patients that will refer to have stress CMR for assessment of stable chest pain between the year of 2008 to 2013. This time period was chosen because of the desire to acquire at least 4 years of clinical follow-up for outcomes and also cost for these patients. So we screened more than 30 sites and used the screening criteria on the sites based on the consecutive volumes during this period of time across these sites. Each site is supposed to have at least 100 cases per year, and also their ability to, and also their history of record keeping and access to electronic medical records among these sites, so that they can perform the study follow-up. So we basically identified 13 sites across the 11 states. So patients were enrolled if they were 35 to 85 years old with evidence of clinical suspicion of ischemia based on symptoms, or a resting EKG in a minority of patients as identified by their caring cardiologists or physicians. And they have to have at least 2 coronary risk factors. We excluded patients who had an acute myocardial infarction within the past 30 days before the MRI, and also those who had a history of bypass surgery. Patients were also excluded if
sorry, Ray, to interrupt you. Can you, while you're doing that, basically walk through the PDF so that people can, while they are talking?
Oh, okay, sorry.
And and don't forget, you have about 8 minutes left, so
okay,
you want to keep in time.
So basically, we enroll these patients to assess them, and the patients with cardiomyopathy were excluded. So why don't I just go straight to the results? And basically, we follow patients for cost and also outcomes. So the first figure, I want to show you the results. This is based on the primary outcomes of acute myocardial infarction or cardiovascular death. Those patients who have, and the graph here is illustrated by lack of ischemia and lack of infarction on the left here, far left, and also on the right here, the fourth column is patients who have both ischemia and infarction. Those who have no evidence of ischemia or infarction have a very low average annual event rates of primary outcome of cardiovascular death or acute myocardial infarction. Whereas those who have both ischemia and infarction have a fivefold increase in primary outcome. A very similar pattern across the average annual rates for the secondary outcome, which is defined by primary outcomes plus late revascularization and cardiac hospitalization. You can see a very similar pattern in the sense that if you don't have any ischemia or infarction, then the rate of secondary outcome is fairly low per year across all 5 years of follow-up. Whereas if you have both ischemia and infarct, the rate is up to 10% for secondary outcome. Now, then I want to take you to this, to figure 2, which is, which illustrates, that was what I just showed you was the average across 5 years. But if you look at each of the 5 years, it's reassuring to show that, again, in the light blue bar, this represents patients without ischemia and without any evidence of infarction. This represents 67% of the whole cohort of 2,349 patients. So 2,349 patients, 67%, that's about 1,500 patients, had, if they have no ischemia or LGE, across all 5 years of follow-up, the event rate for primary outcome was low, indicating that these patients could be non-invasively be considered to be a low-risk group. Whereas if you have ischemia and infarction, the rate of primary outcome of cardiovascular death and AMI proportionally goes up as the presence of abnormality progressively goes up. Now, second, I want to take you to the third graph here. Now, not only do we look, it's important to also look at events, but also look at utilization of coronary revascularization across the years, the 5 years of follow-up. Those 67% of patients, again, shown in light blue here, had at 90 days, 1 year, 2 years, and all the way across to 5 years, had a low incidence of need for coronary revascularization, either by PCI or bypass surgery. During the first 90 days, it's not surprising that as the amount of abnormality goes up by the MRI, either by ischemia or by LGE, ischemia, or both ischemia and LGE, proportionally more patients needed to go through coronary revascularizations within the first 90 days, and also same pattern in the first year. That's not surprising, but it's important to note that 67% of the cohort were low risk, not only in cardiac events, but also the need for coronary revascularization. And I want to take you to the Kaplan-Meier curves here. Now, these are all adjusted for the effects of non-cardiac death as a competing event. But you can see that the Kaplan-Meier curves, as shown here on the first column, these two graphs are the primary outcome, and the column to the right are the secondary outcomes. You can see that in light blue, those people who with no ischemia or LGE had a very favorable prognosis across the years of follow-up. Now, then I wanted to just finish up by showing you graph 5. This is something to do with the downstream cost of what we did was we counted all the downstream non-invasive imaging tests, including nuclear echo, stress echo, exercise treadmill test, and angiogram. Of course, angiogram drives the cost more than the other modalities. We'll also count the CTA and stress MRI as well. And suffice to say that across the 4 groups of patients, not only is not surprising in the first 90 days, those who have no ischemia, no LGE had low cost for these tests compared to those people with ischemia and LGE, which is about a 10-fold increase, which is not surprising, but it's also, we noticed that those 67% of patients that had normal MRI, no ischemia, no infarct, they don't really need a lot of downstream testing in the subsequent years of follow-up, based on the total summary of the cost of these tests. These costs are all standardized to Medicare reimbursement rate to reflect societal burden of healthcare from cardiovascular testing. So, in summary, our findings indicate that a substantial proportion of patients, based on this retrospective cohort from 13 centers, we believe this reflect real-world data as currently the technology is employed in the United States, that it is an effective tool. It can deem a substantial portion of patients to be low risk, and these patients have very low event rates throughout the follow-up of 5 years, and also they have low utility of low need for coronary revascularization and low healthcare costs associated with downstream cardiovascular testing. So those are the summaries of the paper. Thanks.
Thank you very much, Ray. So let me put that basically in a brief summary into context before we move to Sven. And maybe you can unshare your screen so that Sven can already get started. So MR perfusion has been around since about 25 years for those who forgot about that. So it has been extensively used already clinically by some centers. Had a slow start in the US because of the issues around gadolinium. But thankfully, to initiative of Bayer and Siemens, that has now been moved forward, and it's now possible to use gadolinium for that purpose. So perfusion was not just around, but it was also studied in several clinical trials, single-center and multi-center trials, typically validated against nuclear. And the general finding was that it was at least as good as nuclear. But of course, there was some significant information still missing from multi-center trials, and that's why actually 3 landmark trials have been conducted now. We just heard about the SPINS trial. The others, there's a trial that has 2 parts, that has a European and an American, the GATACUT trials. And they are more about the accuracy to identify coronary artery stenosis, and especially for hemodynamically relevant stenosis of 70% or more. It was shown in these trials that CMR perfusion is actually very good. So that's one. And the second one was the prognostic, and that was the SPINS trial, showing, as Ray just beautifully presented, that a normal CMR perfusion scan is basically like a 5-year warranty. That comes with a cost-efficient strategy, so that's very good. But the ultimate goal of any diagnostic technique should be, and although many of the diagnostic techniques that we use every day have never done that, but the ultimate goal is to show that the use of this technology improves outcome, actually is useful, aside from the beautiful images and what have you, but it eventually helps patients to use this technology. And this is what the MR Informed trial was about. It was beautifully designed. Eike cannot be with us today, but I congratulate him here publicly for this. And had a lot of excellent people from the field, including Sven, who I want to thank, especially because he's on service today in a hospital, and was not easy for him to dial in. And then I will give Lon Simonetti a chance to comment on both. But Sven, if you could take it from here and walk us through the MR Informed trial.
Yeah, thank you, Matthias. Can you just confirm that you can hear me okay?
Yes, you can hear you very well.
Right. So thank you for the beautiful introduction. And as you've already outlined, I'm not the leading author on this. I'm somewhere in the middle. Eike Nagel is, of course, the lead for this study. And he can't present today, but I thought I'd just start by showing a quote from him on the trial so you see whom you're talking about. So this is the MR Informed study, which has recently reported in the New England Journal of Medicine. And it's been many years in the making. It was first conceived about 7 or 8 years ago. And that just goes to show how complicated it is to do prospective clinical trials that run over several years and recruit a high number of patients. So this was a prospective clinical study in patients presenting with stable angina, and it was a multi-center trial conducted in the UK, in Germany, in Portugal, and in Australia. And I think it was 14 centers, recruiting a total of 918 patients who presented to normally chest pain clinics with symptoms of typical angina and had to have at least 2 cardiovascular risk factors. That already points to the one of the characteristics of this trial is that was conducted at the higher end of the risk scale. So patients tended to have a pretty high likelihood of having coronary disease, and the pretest probability was, I think, in the end 75%. So certainly at the higher end of where imaging may, as guideline indications go, be used, or whether where patients may go directly for coronary angiography. The randomization then was between a treatment with either cardiac MRI or with direct cardiac catheterization with FFR. And then we just scroll down to the trial setup. I'll maybe do the patient characteristics first. So the patients were randomly allocated to these 2 groups. As you can see here on the patient characteristics, there were approximately 50-50 between the 2 groups. There were no major differences between patients in terms of age, gender, or any of the other important characteristics. The blood pressure was similar. You can see that cholesterol was relatively well controlled. There were about 25 to 30% diabetic patients, 70% hypertensive patients, some patients with previous PCI, so a relatively high-risk population. The majority of patients had class 2 angina. It was a condition of inclusion in the trial that patients had to have chest pain thought to be angina, so there was no CCS angina class 1. Some patients had also symptoms consistent with heart failure, and they were pre-treated already with a significant number of drugs, including most patients on antiplatelet agents and the majority on statins already. As I said, then patients were divided into, or randomized into the 2 groups, as shown here. As typical for these trials, there was a very large number of patients screened to receive 918 patients who were eventually randomized. 16,000 were screened and 15,000 were not recruited. This may seem a large number, but that is fairly typical for prospective trials like this. The exclusion criteria here were all the usual things: contraindications to cardiac MR or interventional treatment, unwillingness to participate, unable to be followed up, but also patients who at the initial assessment were thought to have atypical symptoms were excluded, and that was actually the majority in this trial. So of the 918 that were underwent randomization, 454 were in the MRI group and 464 in the FFR group. The next important result is already in the slide. You can see that 221 of the MRI group had a positive test indicating ischemia. And I should have said that ischemia here was defined as having at least 6% of inducible ischemia on the perfusion scan. Whereas 282 had a positive assessment on angiography and went on to having FFR. So there's a higher number of patients where coronary disease was detected on the initial assessment. Then of the MRI patients, 221 went on to having angiography, out of which 184 had a positive test and 162 were revascularized, whereas there were some that had negative subsequent testing. In the FFR group, 213 were positive on FFR, out of which 198 were revascularized. The main outcome measure here, the main endpoint, was a combined endpoint of major adverse cardiovascular events. And the headline result of the trial is shown here in the Kaplan-Meier curves. So at 1 year follow-up, there was no difference in the major adverse cardiovascular events between the FFR-guided and the MRI-guided groups. You can see that the event rate was so low that unless you magnify into this graph, you can almost see you can't differentiate between the 2 lines. So the insert here is zoomed in just for the top 10% of event rate. And there you can see that there was no difference between the 2 groups over the 12 months follow-up. But you can also see that the event rate at 3 years was only in the order of 3% in either of the 2 groups. So that was the headline result. I already mentioned that there were a few other interesting results. The first one was that the prevalence of disease was rather high at 75%. So the pretest probability was 75%, so this is a relatively high risk group. And then the secondary endpoints that are important to note were that there were more revascularization procedures in the FFR-informed group as compared to the MRI-informed group, which is perhaps important to note in the context of the fact there was no difference in the outcome. So patients who went directly for angiography had more procedures done, but had no benefit in terms of better outcome. There was also no difference in the angina score after therapy. So the fact that in the MRI-informed group, patients had fewer revascularizations did not lead to a higher angina score. So both of these, I think, are important to note when we think about how in future one might use non-invasive imaging versus going directly for choreangiography and FFR. In terms of perhaps the criticisms of the trial, one is certainly that 918 patients is a relatively small study for an outcome-driven study like this one. It was powered around a 10% event rate, which also wasn't reached, as I showed in the previous slide. And it allowed for a 6%, I think, deviation between the two arms before significance was considered. So if you think about this, there could have been a 5% event rate with one treatment arm and 10% with the other, and the results would have been considered to be negative, so they're not statistically significant. Luckily, of course, between the two arms, there was no difference at all numerically, and therefore the study still stands, I think, in its value that it has shown that there's non-inferiority between the two treatment arms. And then because the time is short, I think I may stop here, and there may be some other comments we can come back to in the discussion.
Yeah, thank you so much, Sven, for this concise overview of this truly important trial. Before I hand over to Lon, I have two short questions. One is, so basically this says the event rate was the same, but it was available or achievable with a smaller number of interventions or small proportion of interventions in the CMR arm. Now, I think, for the CMR arm, it was used as 6%, so just one segment was sufficient to call it ischemia. Now, I know in the ischemia trial, we use a higher percentage. So actually, we were more aggressive calling something ischemia. So in the MR-informed trial, although there was a low threshold for calling it ischemia, still, it was a good outcome. So does it mean that if this was done, it would have been done with 10% ischemia, would have been more aggressive, so even less interventions, and would we still be safe? What is your take on that?
Well, the definition was actually, and I didn't explain this in detail, was 2 or more neighboring segments, or 2 adjacent slices, or a single transmural segment. So I don't know exactly how ischemia trials deals with this, but I think most patients in MR-inform had probably ischemia, subendocardial ischemia, in 2 neighboring segments. We call that 6% because the epicardial half of the segment may not look ischemic. My personal experience is quite rare to have complete transmural ischemia, and I think we're probably talking about relatively similar thresholds.
I agree. No, actually, in the ischemia trial, we defined 3 subsegments. So we divided the heart in, so each transmural into 2, one subepicardial, subendocardial. And the other quick question came from Andrew Korestein from Montreal, and I thought this was a good one. What do the FFR guys do about that? How will they not like the study and make arguments of why this study is not worth being implemented in the clinical routine?
I've already indicated that this is a study of 918 patients, which is clearly insufficient to change management. 1-year follow-up with, I think there were 15 events in each of the arms. There is a high probability of even a type 1 error, I think, with such a small sample size, and unless it's reproduced in several thousand patients, I think it's a stepping stone in the right direction, but it's not going to change management. It's going to influence, but not change guidelines.
Yeah, you're good at taking their position. Oh, there's actually another one from Anja Brau from GE Mountain View. Is there cost effectiveness analysis planned based on these results?
Yeah, so there's all sorts of secondary analyses that will follow, and cost effectiveness will be one of those. Also, longer term follow-up. There's quantitative perfusion analysis, which is planned. But I think the key ones will be the 5-year follow-up data, because we would hope that we have a much higher number of events, and we would hope that the benefits or the equivalence of MR in this context will be maintained at a longer term follow-up.
And regarding actually the sample size, I have a kind of a, if you need 15,000 patients to show an effect, I'm actually clinically not necessarily convinced that this is a relevant effect, but that's a different one. So Lon, you are the, thanks for calling in. You are the senior author of the SPINS trial, and I know you have been involved in a lot of discussions. What is your high-level take on that? Do you think that will make a difference for the acceptance of CMR worldwide and in the US? I don't know. I can't hear him. Is he muted? No, he's not muted. So we can't hear you, Lon. Okay. So what? I don't know what it is. We see you're sharing a screen, but we can't hear you. So although the microphone here, as I can see, is on, so you're not muted. Okay, so then I give this question for now to Ray oh yeah, Lon, here you are.
Sorry, I switched microphones there. This one.
Okay, great. Thanks.
Yeah, thank you. I'd like to point people to this editorial by Jörg Schwitter on the SPINS paper. So this is in the same issue of JACC that accompanied it, and I think he really does a great job of pointing out how the prospective trials like INFORM and the registry trial like SPINS offer this complementary data. And from my perspective, from the SCMR perspective, which was my involvement in the SPINS trial, our aim here is to really target the payers and the reimbursement, and especially in the US, where I mean, right now, when you do these cost effectiveness analysis, it's clearly in CMR's favor because the reimbursement is so low. But of course, that's not a sustainable situation. But this kind of data that shows the value of CMR, not only in terms of accuracy, like you pointed out, that GATACAD shows, the prognostic value that SPINS and other registry types trials are showing, and then how it improves outcomes. These can really make a difference with the payers, and that's where I think the SCMR can play a major role. I'd just also like to point out how exciting it was to see the power of the SCMR registry, and what this can do in terms of bringing the field together to really mobilize the community to participate in a study like this. By providing the infrastructure and also the connections to industry for sponsorship. These trials aren't, they take money, they take a significant amount of money to accomplish, but I think the results are going to benefit the entire field.
Yeah, no, thank you very much for putting that into context. So any other questions from others? You can, as I said, you can type that into the chat or ask it by just unmuting yourself. But we're already at the top of the hour, and we always try to keep it short and efficient. So I want to thank especially the presenters, Sven and Ray, for coming and walking us nicely through the papers, and also for Lon for the context here. I think in short, this has been already a very important year for CMR, first pass perfusion, with trials showing that it is accurate, and trials that confirm previous data that it's accurate, that it has a strong prognostic value, and it has a positive impact on clinical management, because that's in the end what it meant to have less interventions, but coming to the same outcome as the current clinical gold standard. So these are very strong signals. So that's why we hope, especially with the GATACAD trials that will still be published, and the FDA rulings, and we have anyways more momentum in Europe, that cardiac MR will be used more frequently, because we know, and also because CMR also provides tons of other pieces of information like function, flow, morphology that can be acquired in the same protocol in a fairly short time. So I think these signals should be strong enough to hopefully move some of the nuclear cardiologists and others who are capable of offering CMR to actually clinically use that. Thank you so much for joining. In 2 weeks, we have our next CMR Journal Club. The papers that we will discuss will be tweeted out, and also invitations will be sent out within the next days.